Hello, my name is Lauren Chastain, and I'm one of the PGY1 pharmacy residents here at the Claremore Indian Hospital. I'm with my co-resident Alyssa, and today we're going to be presenting on anticoagulation. Some learning objectives for this presentation will be to review the Joint Commission National Patient Safety Goal 03.05.01 and the corresponding elements of performance, summarize adverse effects, monitoring parameters, and drug interactions for anticoagulant medications, recognize the importance of medication reconciliation in patients prescribed anticoagulants. We will review the perioperative management of anticoagulants, discuss reversal agents, and describe the inpatient and OB/VTE prophylaxis algorithms. So starting with the National Patient Safety Goal, this was last updated in January 2024. And the goal is to reduce the likelihood of patient harm associated with the use of anticoagulant therapy. So anticoagulant medications are more likely than others to cause harm due to complex dosing, insufficient monitoring, and inconsistent patient compliance. So the corresponding elements of performance are EP 2, 3, and 7. So EP2 states to use approved protocols and evidence-based practice guidelines for reversal of anticoagulation and management of bleeding events related to anticoagulant medications. EP3 states to use approved protocols and evidence-based practice guidelines for perioperative management of all patients on oral anticoagulants. And for EP7, use only oral unit dose products, pre-filled syringes, or pre-mixed infusion bags when these types of products are available. So we wanted to give some background on the medications themselves. So DOACs, or direct oral anticoagulants, they target factor 10A, and so they inhibit factor 10A. These include apixaban or Eliquis, rivaroxaban or Xarelto, and dabigatran, also known as Pradaxa. An easy way to remember adverse effects are just to think that adverse effects are bad. So BAD, B stands for bleeding and bruising, A for anemia, and D for dyspepsia and abdominal pain, mostly with dabigatran. Some key things to remember with administration is that they can be taken with or without food, except for rivaroxaban. This should be administered with food in the evening. Apixaban and rivaroxaban can be crushed. Dabigatran should not be crushed, chewed, and the capsules should not be opened. And another thing with dabigatran is that it cannot be administered via PEG tube. So monitoring with the DOACs annually, we need to monitor renal and hepatic function, and then signs and symptoms of bleeding. So there are a few drug interactions that we wanted to go over. So with all three, apixaban, rivaroxaban, and dabigatran, there is a category X interaction with drugs like carbamazepine, phenytoin, fosphenytoin, and rifampin. So we need to avoid this combination as it can decrease DOAC levels. Same thing with St. John's wort. For dronedarone and the DOACs, there's no data with apixaban, but for rivaroxaban and dabigatran, we need to avoid this in patients with renal dysfunction. NSAIDs also need to be avoided as this can increase the patient's bleeding risk. Potassium bicarb, particularly with dabigatran, needs to be avoided. And then for azole antifungals such as ketoconazole, for apixaban, this can increase its levels, so that would also be putting the patient at increased bleed risk. And then that's basically for all of the DOACs, just try to avoid this combination if possible. Moving on to the vitamin K antagonist, warfarin. Adverse effects of warfarin also include bleeding, bruising. There can be some rare situations with skin necrosis and purple toe syndrome. So for warfarin, requires frequent INR monitoring. We have included some of the INR goals and corresponding indications. So for patients with AFib, if they have VTE, prophylaxis or treatment, and then certain valves, depending on the type of valve or where the valve is, could be an INR goal of 2 to 3, and then an INR goal of 2.5 to 3.5. There is a particular valve called the Onyx that requires less of an INR, so 2 to 3 for the first 3 months, then 1.5 to 2 thereafter. Warfarin has lots of drug interactions, so of note, some of the main ones include antibiotics, antifungals, NSAIDs, and steroids. And then there's also food and drug interactions. So patients need to keep their consumption of vitamin K foods consistent while taking warfarin. For the injectable anticoagulants, such as heparin, enoxaparin, and fondaparinux, adverse effects of these include bleeding and bruising, can cause injection site reactions and anemia. There is heparin-induced thrombocytopenia that we need to monitor, and then with fondaparinux, we can see hypotension. So for monitoring on these baseline and periodically, we need to monitor CBC and patient serum creatinine. With heparin, we need to monitor the APTT and signs and symptoms of bleeding. So now I'm going to turn it over to my co-resident, Alyssa. She's going to talk about perioperative management.
All right, so now that we've gone through the drugs, I'm going to talk about the management of anticoagulants, starting with perioperative management. So for evaluating perioperative management for patients that are on anticoagulants, we first need to determine the procedural bleeding risk. And then for warfarin patients, we also have to look at that patient's thrombotic risk. So when determining bleeding risk, is determined based off of the procedure. So high bleeding risk procedure examples would be any major operation lasting 45 minutes or longer, or hip or knee replacement. Some low bleeding risk procedures would be things such as an abdominal hernia repair, a cataract eye surgery, and then tooth extractions. Simple tooth extractions would be considered low bleeding risk, but they can be more high risk based on how many teeth and the involvement in that tooth extraction. So for DOACs, we want to look at the bleeding risk of the procedure. So if it's minimal, you want to omit anticoagulation on the day of surgery only. If it's low to moderate bleeding risk, you want to omit anticoagulation 1 day before and the day of surgery. If it's high bleeding risk, you want to omit anticoagulation 2 days before, the day of, and the day after surgery. For warfarin, it's a little more complicated, so you look at that procedural bleeding risk. If it's minimal, do not interrupt anticoagulation. If it's low, moderate, or high, then you have to look at the patient's thrombotic risk. If their thrombotic risk is low to moderate, warfarin is interrupted without bridging. If their thrombotic risk is high, you will interrupt warfarin and then also bridge with Lovenox. So now we're going to talk about anticoagulation reversal agents. So for DOAC reversals, this is going to be apixaban, rivaroxaban, and dabigatran. If it's ingested within 2 hours, you can administer activated charcoal. Otherwise, you're going to use Kcentra, which is 4-factor PCC. So Kcentra is used for DOAC reversals, like I mentioned, and it's also used for warfarin reversals when there's a major bleed. Administration, you do not want to exceed 8.4 mils per minute, and do not allow blood to enter the syringe because that can cause a thrombin clot formation within the syringe. Protamine is used for enoxaparin and heparin reversal. It's administered as a slow IV push, 50 milligrams over 10 minutes. Rapid IV infusion can cause hypotension, so you don't want to exceed that 50 milligrams over 10 minutes. Then we have Novo7. It's used for fondaparinux reversal. It is administered as an IV bolus over 2 to 5 minutes, and it also can be used as a continuous IV infusion for certain indications. Vitamin K is going to be used for warfarin reversal, so an easy way to remember that is vitamin K makes the bleeding okay for patients on warfarin. And this can be given orally or IV depending on the INR, the urgency of reversal, and if the patient is currently bleeding. So now we're going to go through our VTE prophylaxis algorithms that we use here at Claremore. So first up is the inpatient one. So first we want to assess the patient, their location. Are they in GMS or ICU? And then we want to assess their risk for VTE development. So we have a lot of factors that we look at, and they're broken down into 3 points, 2 points, or 1 point. So factors that would be those 3 points would be active cancer, previous VTE, reduced mobility, or known thrombophilic condition. 2 points would be a recent trauma or surgery. And then 1 point factors would be if they're elderly, over 70 years old, heart and or respiratory failure, acute MI or ischemic stroke, acute infection or rheumatologic disorder, if they have a BMI of 40 or greater, or ongoing hormonal treatment. And then you add up those factors and add up those points to get a cumulative risk. If they're low risk, meaning they have less than 4 points, no pharmacologic VTE prophylaxis is needed. But if they have 4 or more points, then we would want to use pharmacologic VTE prophylaxis. For OP patients, we have an algorithm for them as well. So we want to assess the severity of the risk. So we have moderate risk factors are broken down into major factors and minor factors, and then we also have high risk factors. So those are all listed out here. So low risk patients are going to be no major factors and less than 2 minor moderate factors. And for those patients, we can consider use of SCDs, early ambulation, and proper hydration. For moderate, which is going to be if they have 1 major moderate factor and 2 or more minor factors, use SCDs with low molecular weight heparin for at least 10 days. If they are high risk, which is at least one of those high risk factors, use low molecular weight heparin for at least 6 weeks. And then there are contraindications to use for low molecular weight heparin in this setting. So if they have a known bleeding disorder, postpartum bleeding, thrombocytopenia, acute stroke in previous 4 weeks, severe renal or hepatic disease, or uncontrolled hypertension, we would not want to use low molecular weight heparin. So the key takeaways from this presentation is going to be that DOACs require annual renal and hepatic function monitoring. Heparin, enoxaparin, and Lovenox require CBC and serum creatinine at baseline and periodically. And then anticoagulants can interact with lots of prescription medications, over-the-counter products, vitamins, and even foods. So medication reconciliations and up-to-date medication lists are very important, especially for patients on anticoagulants. That's all we have for you today. Thank you so much for listening to our presentation.